Imagine, constantly altering your entire wardrobe just to hide potential accidents.
Right.
Like imagine giving up your favorite high-intensity workout or feeling a spike of pure dread just because you feel a sneeze coming on.
Yeah, it's awful.
For up to 35% of middle-aged women, everyday gravity and, well, basic bodily functions have essentially become the enemy. We're talking about a condition that forces people to restructure their entire social lives, yet it remains completely hidden because, frankly, no one wants to talk about it.
It really is the ultimate silent disruptor. I mean, stress urinary incontinence, or SUI, it happens when the physical pressure of a laugh or a cough or a jump leads to this sudden involuntary leak of urine.
Right.
And people just assume it's an inevitable tax they have to pay for aging or having children, like a permanent hardware failure they simply have to live with.
Yeah. But today, we're diving into a stack of clinical sources, ranging from the UK's NICE medical guidance to the Indian Journal of Obstetrics and Gynecology Research, and this really comprehensive MDPI clinical review. And these sources point to a solution that sounds like it was pulled straight out of a sci-fi novel.
Oh, absolutely.
We're looking at transvaginal erbium laser therapy, specifically the ERYAG laser.
Which, I know, throwing the word laser at a biological problem can often sound like snake oil.
Yeah, it does.
But this is a highly practical, minimally invasive alternative to traditional sling surgeries. We're dealing with targeted physics applied directly to soft tissue.
Exactly. And the mission of this deep dive is to answer a very specific, highly practical question for you, the listener. If you're looking into this high-tech solution for mild to moderate stress incontinence, exactly how many sessions of this laser therapy are actually required to treat it?
Right.
And, maybe more importantly, what is the biological science dictating that specific number?
Well, the number of sessions is entirely dependent on how human tissue heals and regenerates. So to understand the protocol, we first have to, map out what is actually breaking down in the body to cause the leaks in the first place.
The structural breakdown.
Yeah.
I like to think of the pelvic floor as like a biological suspension bridge.
That's a great analogy.
It's this complex network of muscles, ligaments, and connective tissue that holds up the bladder and the urethra. When you sneeze, the pressure inside your abdomen violently spikes.
Right.
And that suspension bridge has to provide enough resistance to keep the urethra pinched shut.
And the primary cables of that suspension bridge are made of something called the endopelvic fascia.
Okay.
It's a dense, fibrous sheet of connective tissue that wraps right under the bladder. But over time, that fascia takes a massive beating. I mean, the physical trauma of childbirth physically tears and stretches the tissue.
Sure.
But the real structural collapse often comes later, tied to the hormonal shifts of menopause.
Right, because estrogen drops off a cloud. And estrogen is essentially the chemical messenger that tells the body to keep that vaginal tissue thick and elastic, right?
Exactly. Without that estrogen signaling, the metabolic machinery of the tissue just slows down. The existing collagen fibers in the endopelvic fascia begin to degrade and thin out.
Like an old rubber band.
Yeah, exactly like that. And the little cellular factories responsible for building new collagen, they're called fibroblasts, they basically go dormant. The tissue loses its tensile strength, so the physical scaffolding around the urethral sphincter becomes too weak to hold back the pressure of a cough.
So the hardware has failed. Which brings us to the proposed solution, the 2940 nanometer erbium YA laser, or ERS-YA short.
Right. Now, older generation lasers, like CO2 lasers, they were primarily ablative.
Meaning they burn things.
Basically, yeah. They worked by essentially vaporizing the top layer of tissue, which caused a lot of collateral heat damage and required significant recovery time. But the ERAG laser operates differently. It's applied in a non-ablative or microvadilative fractional mode.
Okay, I have to push back on this entire concept right here.
Go for it.
Because if the endopelvic fascia is already frail and thin and depleted of collagen, hitting it with a laser feels completely counterintuitive. It sounds like taking a blowtorch to a worn-out piece of fabric.
Right.
Why are we burning something to make it stronger?
The blowtorch analogy is a very common fear, but the ERAG laser is performing a highly controlled thermal injury. The secret lies in its specific 2940 nanometer wavelength.
Which does what exactly?
Well, it has a massive unique affinity for water. It's absorbed by water molecules about 10 times more efficiently than an older CO2 laser.
Oh, wow. 10 times.
Yeah. And soft vaginal mucosa tissue is roughly 75% water.
Ah, okay. So it's targeting the water, not the tissue itself.
Exactly. When the laser energy hits the vaginal wall, the intracellular water instantly absorbs that light and converts it into heat. Because the absorption is so rapid and efficient, the laser penetrates just deep enough to heat the tissue without braining or carbonizing the surface.
So it prevents unnecessary heat from conducting into surrounding organs.
Right. And that precise burst of heat does two very distinct things. The immediate reaction is tissue shrinkage.
Shrinkage.
Yeah, the heat physically alters the structure of the existing collagen fibers, making them instantly contract. It's exactly like dropping a stretched out wool sweater into a pot of hot water.
Oh, I see.
The fibers just seize up and pull closer together, tightening the tissue right on the spot.
But the sweater is still old, right?
Yeah.
Like tightening it doesn't make it new.
Exactly. The initial tightening is just the setup. The second effect is the actual cure. By introducing that controlled thermal damage, you're tricking the body's immune system. The tissue believes it's been injured, which triggers a massive wound healing cascade.
Ah, so it wakes up those dormant construction workers you mentioned earlier.
You got it. It activates the fibroblasts. Over the following weeks, those fibroblasts rush to the site of the thermal injury and initiate a process called neocollagenesis.
Meaning new collagen creation.
Right. The synthesis of brand new, healthy collagen fibers. They remodel the extracellular matrix, thicken the walls of the vaginal canal, and rebuild the density of the endopelvic fascia. The body is essentially forced to reconstruct the cables of the suspension bridge.
Okay, so if the goal is to kickstart those fibroblast factories, how much heat is actually required? Like, for someone listening who is dealing with mild to moderate SUI, what is the exact number of sessions needed to build enough collagen to stop the leaks?
So the clinical data across our sources shows a slight initial range depending on the specific proprietary device being used.
Okay.
For instance, the Action 2 Petit Lady protocol mentions a range of 3 to 5 sessions depending on severity. On the flip side, a specific study in the Indian Journal of Obstetrics and Gynecology Research noted that just 2 sessions were often enough to alleviate mild to moderate symptoms.
So you see a bit of clinic-to-clinic variation.
Mm-hmm.
But there's a very clear baseline that emerges, right?
Yeah.
Because the UK's NICE guidance, which heavily evaluates clinical evidence for the National Health Service, along with specialized centers like the Skinning Clinic and the V-Care Laser Center, they all point to a standard protocol of 3 sessions.
Yes. And we find the definitive clinical sweet spot by looking at the MDPI Concise Review, which aggregated the results of multiple international studies.
What did they find?
Well, they evaluated protocols ranging from 1 single session all the way up to 5, and they found that 3 sessions achieved significantly greater tissue remodeling and symptom relief than stopping at 1 or 2.
Okay, so 3 is better than 2.
But the critical takeaway for the patient is that doing a 4th or 5th session provided no additional clinical advantages. Pushing beyond 3 sessions just leads to diminishing returns.
So 2 to 3 sessions provides the exact amount of thermal stimulation the body needs to maximize the neocollagenesis process without over-treating the tissue.
Exactly. 2 to 3 is the magic number.
But there's a massive caveat to that number, because you don't just book a weekend at a clinic and do 3 sessions back-to-back.
No, definitely not.
Almost all the clinical protocols mandate that these sessions are spaced 4 to 6 weeks apart.
Because you cannot rush biology. I mean, the laser is merely the catalyst, right? The
Wow.
heavy lifting is being done by your own cells.
Right.
When you create that initial thermal injury, those fibroblast construction workers need physical time to synthesize, lay down, and organize that new collagen matrix.
It's exactly like pouring a concrete foundation.
Right.
If you pour a second layer of concrete before the first layer has had time to cure and set, you ruin the structural integrity of the whole project.
That is a perfect way to look at it. Giving the tissue a month to remodel allows the initial burst of collagen production to mature.
Okay.
And when you introduce the second laser session at the 4 to 6 week mark, you create a compounding effect. You're layering a new wave of thermal stimulation onto newly tightened, stronger tissue, incrementally building the density.
So at the end of this 3-month process, how do doctors actually prove the suspension bridge is holding traffic?
That's a great question.
Because you can't put the pelvic floor under a microscope while a patient is walking around. So what does success look like in the actual data?
Clinicians measure efficacy using a combination of objective physical tests and subjective quality of life evaluations. The objective standard used in several of these studies is the 1-hour pad test.
The 1-hour pad test. Okay.
Hey,
How does that work?
Basically, the patient wears a pre-weighed absorbent pad, drinks a specific volume of fluid, and then runs through an hour of physical triggers.
Triggers like what? Walking, coughing.
Yeah, walking, coughing, picking up heavy objects, maybe climbing stairs. And afterward, the pad is weighed to measure the exact gram amount of leakage.
Wow. Okay, so it's incredibly precise. And in a 59-woman case series tracked in the NICE overview, a quote-unquote cure was rigidly defined as 2 grams or less of urine leakage during that hour.
Right. 2 grams is a very high bar.
And for patients with grade 1 SUI, which is classified as mild incontinence, the objective cure rate was a staggering 91% at 6 months post-treatment.
It's incredible. And in a larger 161 patient series, they looked at total pad weight reduction rather than just a binary cure.
Okay, what were the numbers there?
The average pad weight dropped from 9.89 grams of leakage at the baseline down to just 3.52 grams at 12 months.
That is a life-altering reduction in physical leakage for a non-surgical intervention. I mean, going from nearly 10 grams to 3.5.
It really is. The physical data is undeniably strong, but the subjective data tells a slightly more nuanced story.
Right, because clinicians use internationally recognized standardized questionnaires to measure how often leaks happen, the volume, and how deeply the condition impacts the patient's daily life.
Yeah, they use tools like the ICIQ-UISF questionnaire. And in that same 59-woman series we mentioned, 72% of the grade 1 patients felt their issue was subjectively cured at the 6-month mark.
So wait, that leaves a fascinating almost 20-point gap between the objective reality and the subjective experience.
Yes, it does.
91% of the women were physically dry according to the scale, but only 72% felt they had their lives back.
It perfectly highlights the lingering psychological toll of stress incontinence. I mean, when you've spent years bracing for a leak every time you laugh, that anxiety basically becomes muscle memory.
Oh, absolutely.
Even when the pelvic floor is structurally sound again, the fear of public embarrassment takes much longer to unlearn.
That makes total sense. So the short-term efficacy at 6 months is robust. But this is the moment in the deep dive where we have to deliver the catch.
Yeah, we have to talk about longevity.
Because the data at the 12, 24, and 36-month marks paints a very different picture.
It does. The MDPI review explicitly notes a measurable reduction in the clinical effect between 6 and 36 months. Going back to that 59-woman study, the 91% objective cure rate for grade 1 dropped to 78% by year 2.
Okay, so it drops. And the subjective cures.
Those dropped from 72% down to 66%.
And the drop-off is even steeper for women with grade 2 or moderate SUI, right?
Yeah.
Their objective cure rate went from 69% at 6 months down to just 50% at the 2-year mark.
Yeah.
It's essentially a coin flip at that point.
Right. But the underlying biology explains this perfectly. The laser stimulated the fibroblasts and rebuilt the collagen, but the laser did not freeze time.
Right.
The natural aging process is still happening. The estrogen deficit of menopause is still a daily reality. The physical pressure of gravity is still bearing down on that endopelvic fascia every single time the patient stands up.
So the suspension bridge is still carrying heavy traffic. The newly synthesized collagen eventually begins to degrade, just like the old collagen did.
Exactly. Completing those initial 2 to 3 sessions is not a permanent, one-and-done surgical fix. The science points to a maintenance reality.
Maintenance meaning you have to keep going back.
Yeah. After the initial protocol, annual maintenance sessions are highly recommended. You have to periodically go back in, introduce a mild thermal injury, and remind those fibroblasts to keep working to sustain the tissue density.
Knowing that this requires an initial multi-month commitment, followed by an annual return visit forever, the practical reality of what happens in the room becomes a huge factor. What is a patient actually signing up for? Like, what is the experience?
Well, the procedure is remarkably fast and entirely outpatient. It generally takes about 15 minutes.
15 minutes.
Yeah, that's it.
Okay, so the clinician inserts a specialized speculum into the vaginal canal. They typically start with a 360-degree handpiece, delivering fractional laser pulses to the entire circumference of the canal.
Right.
Then they often switch to a 90-degree handpiece for targeted irradiation. Why the switch?
Well, that 90-degree targeting focuses specifically on the anterior wall. That's the front wall of the vagina, which acts as the direct anatomical floor beneath the bladder and the urethra. By hyper-focusing the thermal energy there, they ensure the most critical support cables get the maximum collagen stimulation.
Got it.
And then they usually finish by treating the vestibule and the introitus, which is the external opening of the vaginal canal.
Now, because the REA wavelength is so perfectly tuned to be absorbed by water rather than burning the surface, our sources emphasize that the procedure requires Zero anesthesia.
Right. None at all.
No needles, no topical numbing cream. Patients report feeling a mild sensation of warmth or maybe a slight vibration.
And that lack of surface ablation means there is zero social downtime. The patient can get off the table and immediately drive back to work or resume normal daily activities.
Okay, but you can't just pretend nothing happened. I mean, you just intentionally injured your tissue to trigger an inflammatory wound healing cascade.
Yeah.
You have to protect that process, right?
Yes, absolutely. Patients are strictly advised to avoid sexual intercourse for 72 hours.
Okay.
They're also told to avoid heavy lifting, intense core workouts, or anything that creates severe intra-abdominal pressure during that 3-day window. The tissue needs a quiet, undisturbed environment to allow the fibroblasts to begin the remodeling phase.
Okay, so let's summarize this. 15 minutes, no needles, no pain, immediate return to work, and a 91% cure rate for mild cases at 6 months.
It's pretty wild.
It sounds dangerously close to a miracle cure. And that means we have to look at the downsides and the risks. What actually goes wrong?
Well, impartially analyzing the adverse events is vital here. In the clinical studies reviewed by NICE, about 11% of patients reported experiencing weak, transient pain during or shortly after the treatment.
Okay, 11%, but you said transient.
Right. This pain was restricted to the first few days and resolved entirely on its own without requiring medication.
Got it. And about 2% of patients reported a temporary increase in vaginal discharge as the tissue responded to the heat, right?
Yeah. But there were no reports of massive surgical complications. No systemic infections, no heavy bleeding, no permanent scarring in these specific YE cohorts.
That's reassuring.
Yeah.
But the patient selection criteria is also incredibly strict, isn't it? This is not a blanket cure for all bladder issues.
Oh, not at all. The study specifically excluded patients with pure urge incontinence.
Right, because pure urge incontinence is essentially a software problem, not a hardware problem.
Exactly.
It happens when sudden erratic nerve signals tell your bladder muscle to squeeze, even if it isn't full. A laser treating the structural connective tissue beneath the bladder will do absolutely nothing to fix misfiring nerves.
Right. It also excludes patients with active infections or severe pelvic organ prolapse. It is a highly targeted therapy for a mechanical failure. But, and this is a big but, there is one major vital caveat found in our stack of sources.
This is from the clinical consensus statement, right?
Yes. From Voices for PFD, which is an organization focused on pelvic floor disorders.
Right. And their consensus statement acknowledges that the data overwhelmingly shows these vaginal energy-based devices are safe and effective in the short term. But they firmly highlight that the long-term safety of repeatedly heat-treating vaginal mucosa is still unknown.
That's exactly it. We have robust clinical data tracking outcomes at 6 months, 12 months, and 36 months. We do not have 20 years of longitudinal data to know if there are any decades-later side effects to annual thermal injuries.
Because this technology, applied specifically for stress incontinence, is still relatively young in the grand timeline of medical science.
It is. It requires a patient to make an informed decision based on the data available today, weighing the immediate restoration of their quality of life against the unknown variables of the distant future.
Which reinforces why this is a medical intervention altering cellular biology, not just a casual cosmetic treatment. It requires thorough evaluation by a qualified specialist.
Absolutely.
So let's bring all this data together and answer the core mission of this deep dive for you. If you are dealing with the hidden daily frustration of mild to moderate stress urinary incontinence and you're evaluating transvaginal erbium laser therapy, the science dictates a very clear roadmap.
It does.
You're looking at an initial protocol of 2 to 3 sessions. Those sessions must be spaced 4 to 6 weeks apart to give your fibroblasts the biological time required to build a new collagen matrix. And because gravity and hormonal changes will continue to wear away at that new connective tissue, you should expect to schedule an annual maintenance session to sustain your results.
And, using controlled, targeted light to trick the body into reconstructing failing structural connective tissue in the pelvic floor is just a brilliant application of physics.
It really is.
And it opens the door to a fascinating question. If we can manipulate fibroblasts to rebuild the suspension bridge of the bladder, what other hidden, failing connective tissues throughout the human body might eventually be reversible with this exact same approach?
Reversing structural aging with targeted light. It is a wild thought to leave you with. Thank you for joining us on this deep dive. Keep asking those questions. Keep looking for the why behind the what's, and keep seeking those aha moments. We'll catch you next time.